thanks for having me again. I've got a few problems according to my close family, one of which is I do talk fast and I'm going to try to slow my speech. I don't have many slides because thankfully, exactly what Dr. Edwards said is really what I want to focus on here. You guys don't need to know the nitty-gritty of how we do digital replants, even though you'll find out that we do not do them at Albany Medical Center, and I'll hopefully explain why by the end of this talk. But I really do want to focus on the pre-arrival stuff because one of the main points I want to get across is still in the situation that you will be in the field and potentially have an amputated part of a limb or a finger. There's a few steps that are pretty straightforward and sometimes commonsensical that I want to make sure I pass along to you, but then at the same time we're still going to try to get them, if it's within our catchment area, to us potentially first, because the decision of what we're going to do with that isn't always cut and dry, no pun intended. And so we want to resuscitate the patient first and look at the whole patient, and then we do have some leeway in terms of times that then we're going to make a decision whether or not we're going to transfer this to one of the regional hand centers. I don't have any. Oh, so hold on. So if you're at home and there's any kids around, there are some pictures, obviously, of fingers off. So this is my public service of listen, make sure there's no kids overlooking this, because there are some gruesome pictures. Okay. I don't have anything relevant, certainly financially, to disclose. But I do give a shout out to my colleague and friend, Dr. Marinello, who's a little bit closer to fellowship than me. So he had some more recent good pictures like this one. I've got some from my fellowship training at Harborview in Seattle, because we obviously saw some pretty gruesome upper extremity stuff. So I got a couple of those. So just warning you, if there's kids around, don't let them see your computer screen. Okay. So my first main point that I want to get across is replantation is the restoration of the amputated part. I'm going to really focus on digital stuff, but a lot of what I talk about just applies in general upper extremity replantation. When a hand surgeon undertakes this and the team undertakes this, the goal is not just to have it live, right? Why are we doing it? Because we want to improve that patient's quality of life and their function. And to some degree, even though it's not why we do it solely, but it's not an insignificant thing to consider, is the cosmetic or aesthetic appearance. Okay. Again, a lot of themes here that I want to just keep hitting. Replantation is an incredible endeavor. It's one of the main reasons why, despite being the busiest level 1 trauma in New York State, as Albany Med is, this is one of the things that does not fall under our purview to do replantation. And a lot of that is because of the resources involved, the time involved, the cost involved. There are a lot of resources required. When I was at Harborview in Seattle, there was always 24 hours a day, 7 days a week, 1 to 1.5 full surgical teams available on call at any given moment to be able to sew extremity or a digit back on. And that is something that affects the flow, because sometimes that happens right smack in the middle of the day, right? And what happens if you don't necessarily have a room available? Well, that's gonna push out elective cases, right? You also have something where there's a lot of secondary surgeries. You may have to take that patient back because one of the digits that you sew on does not look too great, and you have to revise that replantation. And so you have to have a team available at all times. You have to have a team available that's going to take care of it post-operatively, which is usually, an ICU or a step-down setting. And so, what I want to make sure comes across is it's like, okay, we're a level 1. We take everything. We do everything. Why don't we do replants? Well, a lot of it's on this slide, but then as I go through, you'll understand, that there's a lot of steps in place and a lot of resources that are required. The other main point here is whenever we're making a decision to say that this digit or part of the extremity needs to be replanted, and then I guess more specifically to the digit, we're always debating on, with factors that I'll hopefully explain, is that, hey, is this a situation where maybe just revising the amputation, given the patient's picture, is actually going to be the most advantageous thing for that patient. It's going to get their function returned quicker. It's going to cost less resources. That's not the sole reason why we make these decisions, but you can't say that some of those are not a factor in them. And I'm going to get to a lot of the patient specific and injury specific concerns throughout the talk. We see a lot of hand injuries. Like Dr. Edwards said, probably all of the, pre-arrival people that are on this call have had a situation where there's been a significant laceration to the hand, if not a true traumatic amputation. And hand injuries are a super frequent call from my emergency department colleagues for consultation. Just in general, all comers, some epidemiological studies have said, 10 to 30% of trauma-related visits are hand injuries, right? In general, when you talk about digital amputations, there's 45,000 every year in the United States. And while I'll give you a little bit of history on sewing fingers back on, which really started in the 1960s, our surgical techniques and our technology always is improving. But as I'll hopefully explain, the decision to whether or not you attempt to sew that finger back on is more challenging and complex. So here's that little history slide, an ode to Malton McCann. Mass General did the first reported it was a more proximal replantation in the 60s. And then Dr. Kleinert, who I am sort of a disciple of because he's got this training tree of all these hand surgeons throughout the United States at the Kleinert Institute out in Louisville. And one of his disciples was Doug Handel, who trained me at Harborview in Seattle. And then the first thumb was sewed back on in Japan in the late 60s. And then also around that time, there was the first toe to thumb transplant. So just a little brief history about, this is really only since the 1960s that we've been doing this in the medical field. But there's a lot of recent trends that we notice in the hand surgery world and has probably been noticed by our emergency providers and traumatologists, is that there's definitely been a declining enthusiasm for replantation over the last 2 decades. Especially when I was in fellowship training, which is now 15 years ago in 2008 to 2009, there weren't a lot of replants going on. And there was a lot of different pontification about why that was happening. A lot of the ideas are on this slide. Yes, we've thankfully have improved industrial standards out in the factories in the field and more safety mechanisms in place. So we're preventing more injuries. Which is hard to quantify, but obviously is going to play a role in this. Lower reimbursement rates, unfortunately, things do come down to money sometimes, and like I said, the cost is not an insignificant factor in this. Like I mentioned, the cost-benefit ratio of do you revise the amp, do you attempt to replant, and then as you'll see with a bunch of my slides, our indications definitely have been more selective. There's very few absolute yeses and nos. You'll see on my slides that a lot of what I write and a lot of hand surgeons would agree that there's a lot of relative to the indications and contraindications. And even though this was 10 years ago with the most recent study, historically, the rates of success of replants are good. And I would still say that if you're doing a replant at a regional hand center, higher volume, because that's where they go, the success rates are good. It's not that the success rates are poor, but I think that they were kind of maybe overinflated with those initial studies. And people were like, well, really, if you kind of look at this, and this study was just 10 years ago, their success rate of replant survival in this one study that had a few dozen patients in it was only 57%. So, there's also the thought of, are we really doing something that is as successful as was historically described? Again, I apologize. A lot of these surveys and database studies are a little bit outdated in terms of they've been in the last 20 years, but nobody's really looked at this more recently again, which I think we probably should. But back in 2007, in a big database study, only 50% of hospitals themselves performed replants. And then if you looked at those hospitals, only 2% of them did more than 10 cases a year, and 60% of those hospitals that were doing replants only had really one a year. And I think even in my fellowship year, and I was at arguably the busiest level one trauma center in this country. I know shock trauma and Harborview always, kind of, debate each other. And maybe now there's the one in Texas that's pretty busy, but Harborview's, definitely in the top three. And that year, and across we had 4 fellows, multiple hand attendings. I think that year there were maybe 4 or 5, like one per fellow, true replants. And we're taking everything. So we have a large catchment. We had like a 4-state catchment area. So just a little bit of perspective on it. They did a survey to all of us in our National Hand Society, which is made up of general surgeons that are hand specialized, plastics and ortho, and they got a really good response rate. Anybody that knows survey data, if you get over 15%, you're doing pretty good with a survey. This survey almost had a 50% response rate of all of the members of our hand society back in 2007. And it's shocking. I'm almost embarrassed by some of these stats. Certainly, I take emergency hand call, and the way we do call here. Luckily, there's 8 hand surgeons. If one of my orthopedic colleagues is on hand and not a hand surgeon but needs us, we're a phone call away. But 30% of them didn't even take emergency hand call. 40+% of them didn't offer microvascular surgery. And then just as a perception, opinion, 74% of those respondents, definitely thought that there's less and less replants being done across the country. And then this other one, the 2010, database study, only 47% of level 1 trauma centers had emergent micro and replant services available 24/7. So again, for those of you out there that be like, okay, Albany Med is the busiest level 1 trauma in New York State. Okay. Yeah, we don't do this, but we're not alone. Half of the level 1s in this country don't do this. So we're not alone, and we're probably still in the majority, even though we've got some academic people in our world that are advocating to change that. But I think the compromise has been, making some of these other more regional centers, and not necessarily every level 1, although I think they would like that, but making these regional hand centers more supported so that we can take care of these patients. So again, gory pictures, so get the kids away. The decision for replantation is at the discretion of the accepting hand surgeon. So another salient point that I want to get across is, like everything in life, whether you're talking to your significant other, your children, your pets, colleagues in the emergency department, communication is key. And I'm going to go through a couple of the things that they'll likely ask you and talk about, but you want to make sure you're communicating as best you can. Now, in the digital world, and with new EMRs, and excited about Epic and being able to communicate better on an electronic medical record standpoint, the advent of pictures has been helpful to get a better idea of what you're dealing with, rather than describing something over the phone. Because there's always this caution with promises made. The way we work at AMC is that if the ortho residents or the plastics residents get consulted on a hand injury in the emergency department, and they're the first look at, hey, is this something? And what I've instructed them is, if you have any question of this is something that may be amenable to an attempt at replantation, they bump it up to us, and know that they can call me and be like, okay, what do you got? I'll look at pictures if needed. We'll describe the injury. And then a lot of times I've seen lately that the potential accepting referral hand center is going to want to know that at least a hand surgeon looked at it, and to make that decision. But again, I'll have more info on that. So you want to do an assessment of the amputation, and there's a lot of part-related factors: where it is, the injury level, the mechanism of injury is super important. What's the condition of the tissue? And as I'll get to more specifically, what's the warm or cold ischemia time? And I'll explain that. But in a nutshell, cold is if that amputated part is on ice. I'll tell you how to do that the most appropriate way. And then warm is it's not been on ice. Obviously, cold we'll be able to keep that tissue viable longer. So that ischemia time will be, that window will be longer. And I have slides on that, don't worry. And then there's patient related factors. You can't, you can't understate or overstate, sorry, the importance of, you have to, that's why a lot of these patients, if it's a multi-trauma especially, and part of their injury is a traumatic amputation, they need to be evaluated at our level 1 if we're the closest, because we need to engage our ATS protocols, do our ABCs, manage the polytrauma like we do so well here at the medical center. And then we also have to factor in, did you guys in the field to control hemorrhage have to put a tourniquet on? Because that's going to affect, we have a clock. Okay, a tourniquet can really be on for a couple of hours, and then you can take it off for 15 to 20 minutes and you can put it back on. But that is going to factor into some of the patient factors of that amputation. Here's my push for communication, right? When you're talking about whether or not you're going to replant versus revise the amputation, there's a huge surgeon to patient conversation, right? There's different things about the patient's health status that are going to be important to know. We know from data on the largest databases on replant outcomes, if you're a smoker or you're a diabetic, you've got a much higher chance of the digit not surviving the replantation. You got to think about what are your functional and aesthetic outcomes going to be when you have that conversation with the patient, and you have to make them aware this is not going to be their last surgery potentially. Like I talked about before, they may need to go back if we're having trouble with the viability. It may need ultimately a revision amputation if it fails. So you have to have those delicate conversations at a time where obviously, the patient's in distress about the amputated part. You can't discount the patient-related factors of, like, what is the socioeconomic implications? Is there a cultural reason why, even though it may not be an indication to try to sew it back on, that if they don't have their limb is a huge issue in their culture or in their family? There's also to think about, like, getting back to work, like what kind of work do they do? The patients that undergo these surgeries are going to utilize the healthcare system a lot more, and the rehabilitation is not insignificant. I mean, you tell people this is a 6 month to a year of where they're going to be, in terms of if you have a successful replant. So this may be, for the pre-MS people, the most important slide. So I will go slow. Okay. How do you prepare the amputated part of the patient in the field? Okay. And sometimes that's going to be when they come to the emergency department too, but a lot of the guys and gals in the pre-arrival setting are going to be the first, the first to evaluate this patient. So I wrote it simple but critical. Okay. Any part, if it's, even though you don't know that it's going to be sewn back on, any part that's available, any tissue that's there in the field, take it. And the reason for that is because even if there's even just some skin that is, like, a quote unquote spare part, right? But we can use that, like, anything in our armamentarium, if we need to do any grafting or something like that, with the patient's own tissue, so any part, even if it's segmental, you don't leave it in the field. Okay, take it. You want to do, it could be cursory, but if it's contaminated, it's dirty, you want to do a little bit of saline on it. You want to clean it as best you can. You want to wrap it in just a little bit of a moist gauze like they're showing here, and then put it in a bag and then put it on ice, whether that's an ice pack outside the bag or ice in another bag. You want to avoid the direct ice on the amputated part because there could be a potential for a freeze injury, but you do want to keep it as cold as possible. And the reason for a little bit of moistened gauze is you don't want the tissue to desiccate and dry out. So you want a little bit of moisture to it. Wrap it in the gauze, then you want to put it in the bag, then you want ice on that, whether it's an ice pack like this, or you want to fill another bag with ice, and then that bag that has the amputated part with the gauze, you put inside that bag. That's your best way of handling it. Okay. Pretty straightforward, but Sometimes it's like, okay, what do I do? Right. So, just as a recap, you want to take every part that's there, even if you don't think it's usable, because it may be. You want to clean it cursorily, especially if it's grossly contaminated. You want to wrap it in the saline moistened gauze. You want to then put that on in a bag and then ice outside that bag that could either be inside another bag or like this, an ice pack. And you got a little, like cooler for it. Um, so that's how you handle it. And then again, not lost on all of us is, it's like orthopedic residents, and I tell them their knee-jerk response when they get the call from the ED of an open fracture. You have an amputation, what's their tetanus status? Get antibiotics started, right? So tetanus status, antibiotics as soon as they hit the door. And then you want to adequately resuscitate that patient. Dr. Edwards and I were talking before we started this talk this morning about, when it's more proximal, and obviously not the focus of my talk, but you're more worried about significant hemorrhage the more proximal the amputation is going to be, right? So that patient needs to be adequately resuscitated. They could have lost a lot of volume in the field. They might have a tourniquet on by the pre-arrival EMS before they get to our ED doors. So we have to adequately resuscitate that patient. We have to engage in our ATLS protocols, and then we can, once the patient is stabilized hemodynamically, then we can say, okay, what are we doing about the amputated part? Okay, so my cadence of speech was slow. I repeated this slide two or three times. This is for pre-arrival people, the best advice on how you handle this. Okay. Very briefly, because again, the focus of this talk is not to bore you of how I did this 15 years ago when I was a fellow and how they do it at the hand centers that we don't do. But again, the OR team is crucial that understands the implants that are required. A lot of people do it under a microscope, but I had an elderly surgeon, Dr. John Sack, who would do all of his replants under just high magnification loops, which was always impressive to me, and he had just as good outcomes as other guys. We're using very small micro instruments. You can see, just to kind of give you a picture of, okay, the suture and the needle here in relationship to the size of a penny, right? I mean, we're working with small stuff under a microscope to sew these vessels together. It's a different skill set. I'll be honest. I had a lot of micro in my fellowship, not because I said we didn't do a lot of replants, but we did a lot of free flaps, and tissue transfers and things like that. And I had the luxury of, I could have a choice in my fellowship. Hey, do you want to scrub the cases with the micro, or do you want to scrub the elbow that's been operated on 8 times with multiple fractures and it's stiff and all that stuff. And as an ortho guy, I kind of gravitated towards those other cases because the micro stuff was not for me. It really takes keeping up on this. I mean, you saw some of those anecdotal database studies where, people are only doing one a year. That's hard to keep up on those skills if you're not doing microsurgery on a more frequent basis. Just like all of us in life and what we gravitate towards in practice, it's a skill set that you need to keep up with. So it takes a lot of training and it takes focused practice. Just a couple of other slides about, the basic instrument trays that we use: vessel dilators, small micro clamps, vein couplers, things like that. But again, not boring you with the details. Here's another crux of my talk. I put the lady in the scales there, the justice scales, because you're always weighing things. What are the pros, cons of, does this patient meet the criteria for you to have that conversation with the regional hand center for transfer? And I kind of broke it down a little bit into patient factors, injury factors, and some circumstantial factors that are what you're dealt with when it presents to you. The relative indications under the patient factors. And again, it's all relative. There are some absolutes that you're going to always try, and there's some, that some would argue are absolute. But if you look at a lot of the academic literature, everybody says it's not necessarily hard, fast rules. There's ones that you're more likely to do it and ones that you're much less likely to attempt it. So a lot of this time, this I wrote relative, because there's not a whole lot of absolutes. The patient factors: young patients with with amputations are going to do a lot better if they're attempting a replant than older patients. The tissue is a lot more resilient. I joke with my residents that like young infants that get that fingertip, and again, not the focus of the talk more proximally, but the fingertip caught in the wedge of the door, which is a frequent thing that we see, and it's really just the tip of the finger. I mean, they're almost like starfish. They're going to almost regenerate the tip of that finger, which is unbelievable. That does not happen in adults. You want to always individualize this. I want to know when the residents are talking to me about a hand injury, okay, what's their hand dominance and what do they do for a living? And that's super important when you're talking about are they a candidate for a replant or not? What's their occupation? What are we trying to get them back to? What's their medical history? I mentioned diabetes and smoking, we know have poorer outcomes if a replant is attempted. uh, Social and psychiatric issues. I mean, I can give you one example of fellowship training. Unfortunately, someone with a significant psychiatric illness cut off multiple fingers, and they attempted to put them back on. And about 3 days later, I think, he found a way to cut them off again. And so a lot of resources and time and energy went to sewing the fingers back on, only to have a few days later, the patient who was very troubled mentally do the same thing to themselves. So you have to factor that in, unfortunately. And then again, what are your expectations? You have to set those with the conversation with the patient. Listen, if we're going to try this, you are in store for months of rehabilitation with hand therapy and the like. Some injury factors. We talk about clean lacerations. Well, if you think about the most common thing we see is probably a mechanism of a table saw, right? A table saw isn't really truly sharp. This is not a machete or a thin blade. It's usually a jagged edge with what's called the kerf of the blade is several millimeters. And so you're going to actually have a loss of tissue, not just a clean cut. So it's always like, hey, the misnomer of, oh, it's a table saw. That means it's a clean, sharp laceration. Well, not always, okay? You want to have somebody, if you're going to think about a replant, have limited crush. I'm going to show you a gruesome picture in a few slides where it may not look it on the outside, but if there's traumatic injury, more proximal or distal with crush as the main mechanism, that does not bode well for trying to do a replantation because the zone of injury is too extensive. And you obviously want as limited contamination as possible. It goes back to if there is some gross contamination of that amputated part in the field, try to pick it off grossly, try to just rinse it off as cleanly as you can. I mean, I'm not expecting you to scrub it down, but again, the cleaner you can have it with the more limited contamination to minimize risk of infection if they are going to attempt a replantation is critical. Circumstantial factors. Dr. Edward wanted this on the slide, okay? So it's right here for us. What is acceptable ischemia time? Okay, now the literature is going to vary, and you're going to see like one of these that there was some outliers. But the key is if you are able to keep the parts on ice, you have more leeway. You have what's called a longer cold ischemia time to be able to attempt a replantation, which especially in our region is going to be helpful because we're sending those to one of the regional hand centers if they're going to attempt replantation. For a digit, you have more time than you do a more proximal amputation. The reason for that is very clear. If you have a more proximal level, there's a lot of tissue damage distal. You can have what's called myonecrosis where the muscle dies. That's going to make our window a lot smaller. So for a digit, what we call the warm ischemia time, if the digit is not on ice, is anywhere from 6 to 12 hours if you look at the literature. The cold ischemia time, if you're able to keep it on ice, is anywhere from 12 to 24. But there are reports out there of several days later. We actually had one in my fellowship year, which was a finger replant that they had kept on ice at an outside facility. It got transferred to us, and then we ended up putting it back on, I think, 36 hours later, and had a successful replant. So again, the cold ischemia time is longer, and ideally you want it 12 hours. Warm is 6, but like I said, you're going to see ranges in the books. When it's more proximal, it's really a lot shorter. Warm is only 2 to 4, and cold is 6 to 8. So even though that's not the focus of my talk, The major amputations, like I showed that picture of, where it's at the upper arm level, you have less time to make that decision and get that patient adequately treated. Okay. Again, I put it in parentheses, but what are our absolutes? So, what are the ones where it's like if this patient read the books and sustained this awful injury exactly the way we want to do it to try to do a replant, what would be the things that we're looking for? So, thumb is always a priority. That's what separates us on the evolutionary tree, the opposable thumbs that we have as human beings. Anytime where we want to try to attempt at getting the thumb back, we're going to do it. Multiple digits, okay? Partial or total hand palm, the proximal ones that are more clean with less of a crush. This is one that's not intuitive to a lot of smart people. I've had a lot of smart people talk to me about an individual finger and where they think it's more advantageous to replant. It's not the more proximal you go on the one digit. And the reason for that is if you remember anatomy, you have two flexor tendons, one, the FDS, that splits into two tails and bends your proximal IP joint, and then the flexor digitorum profundus that goes all the way out to the tip of the finger to bend it. Ideally, for an individual finger replantation, we want that laceration to be at the level that is distal towards the tip of the finger, past that FDS insertion. So people would think, oh, you want to sew on more of the finger, so it's better to actually have an injury where you're closer to the big knuckle. Wrong. You want to be, ideally, if you're doing a one-digit replant, you're looking at that level at the middle phalanx, distal towards the tip, past that PIP joint. And that's because with this anatomy, there's only one tendon there. Okay. So when you get into what we call no man's land historically in the hand world and zone 2 of the flexor tendon, where you have two, and sometimes if you think about it with these tails, three tendons, trying to sew that back on and have there be any usable function of a viable stiff digit is not good. And of all these digits, actually, an extra credit trivia question would be, if you're going to have one awful stiff finger of the 5 fingers in your hand, which one do you not want it to be? And the answer is the index finger. And that is because then the thumb can't get to the other digits. Because if there's a stiff index finger hanging out in the breeze, you can't bring your thumb over for grip. Okay. Anytime a pediatric patient comes in with an amputation, regardless of the level, we are always going to have more of a sphincter tightening to be like, hey, this is somebody that needs an evaluation for possible replantation, because kids have that capacity to heal that if we could bottle up and give it to an adult, we'd be a lot more happy in our world of treating injuries, right? But the kids are so resilient. We want to do whatever we can to restore their function because their outcomes, it's interesting. The literature outcomes of kids are actually a little bit worse, but there's an academic reason for it. It's because more are attempted in kids because we know that we have more of an ability to potentially salvage a child. So even though the numbers may say, hey, of these patients that were taken, but we're taking more patients, relatively speaking, that are pediatric with these injuries because we're trying to do everything we can to save the part. So this is probably the worst picture I have. This is actually mine. This is from my fellowship training. This is an unfortunate patient. We had a lot of military bases around where I trained in fellowship, and this Army Ranger, he got thrown off a Humvee, and then the arm got caught in the wheel. And so it kind of traumatized, not only with this traumatic amputation, but also, even though the picture doesn't do it justice, you see the laceration up here, the wheel actually ran all the way up the arm. And so here it's like, okay, it's a more proximal level. It's through the level of the forearm. We want to try to do what we can. But the zone of injury here and the crush was just so extensive that it was unfortunately converted at the time to above elbow amputation because the zone of injury here was just too extensive. So multiple factors on this contraindication slide. All right. Life-threatening injuries. Okay. So life over limb, right? So ATLS protocol, if it's a polytrauma, patient's exsanguinating. There's a lot of other issues going on. They could be an extremis. ATLS comes first, obvious, but I put it as the first bullet point. What I just mentioned with this unfortunate case, if it's mangled, if it's segmental, if there's a crush mechanism, that's not a great indication to try to put the part back on. The avulsion injuries, which I have one little case slide to show you where the finger is sort of, amputated but ripped off in the process, those can be pretty difficult and a relative contraindication because there's oftentimes disruption more proximally of the intimal lining of the vessels that make it very challenging to sew back on. If a patient's got significant vascular disease, again, going back to some of the medical comorbidities, again, the conditional things that I mentioned about what's your warm and cold ischemia time. So that's an important piece of documentation from pre-arrival to the emergency department, any psychological issues that the patient may have. And then I mentioned again, common theme, individual finger in adult, which is proximal to FDS insertion, relative contraindication. Okay. When we actually take these to the operating room at the regional hand centers, we have a typical order that we do. We first want to identify vessels. The most important thing that we do in trauma is always the initial debridement. So if it's contaminated, we want to wash it out thoroughly. This goes to us with open fractures here at the Med Center. But in a setting of trying to sew a finger back on, we obviously want the cleanest tissue bed that we have. So the debridement is super important. When we stabilize the bones first, a lot of times we err on the side of shortening them, makes things more straightforward for us, so that things not only are not under tension, but also, we have more bony stability because usually, again, these fractures may not be just clean cuts. Then we look at the tendons, then we look at the digital artery supply, then we look at the digital nerves, and then lastly, the outflow in the veins before soft tissue closure. So this is a picture of, I think this is one of Patrick's that he gave me. It's essentially an amputation. You can see there's maybe just a little bit of a volar skin bridge, but both digital arteries are out. The bony deficit was through the level of the PIP joint. So in order to salvage that joint, basically they shortened it, and then this is actually to fuse that joint so that that joint won't eventually move, so that they could have a stable construct to sew the finger back on. There's that one case I mentioned of the avulsions. You get this ribbon sign with the remaining portion of the vessel, which is not going to do well in terms of trying to sew that to get flow restored. Yeah, that's the clinical photo of that. You can see how it was basically an avulsion and just ripped off. And those mechanisms do not bode well for attempt at replant. So this was a revision amputation with a little flap of tissue over it. That's just a case example. I'm almost done, but you got to talk about costs. Unfortunately, healthcare is a business and we want to take care of patients, but we realize that these things are costly. I wish there was more recent data, but what I could find with recent reviews was, just in general, table saw injuries. This was 2009. It was, a $14,000 average cost with 40,000. Lost wages of 14,000, sorry, and then medical costs averaging 40 grand. The replant return to work after a replant was 125 days, where it was 2 months if you just did the revision amputation. My buddy Jeff Friedrich out in Seattle, he did another kind of view on cost, and about 10 years ago or so published this, and the average hospital stay for a patient with a replant was about 6 days, costing $40,000 to the healthcare system. And then the revision amputation, which I think there's other factors in that and a lot of confounding variables, but it definitely was shorter by a couple of days and almost $20,000. So a lot of the points that I want to just summarize and I hope I accomplish what Dr. Edwards wanted me to with the pre-arrival people and our ED staff is, if we're going to be successful in this, it relies on several factors, the most important of which is patient selection, is understanding all those different factors that I told you, some on the injury side, some on the patient side, and understanding that you need all that information to make the best decision for the patient. Again, just a review on, like I wrote, relative on both, relative indications, thumbs we want to try to replant as often as possible, multiple digits, single digit distal to FDS insertion, hint, hint, and any level in a child. Our relative contraindications, again, are significant crush injury. If there's a segmental deficit, you've got two lacerations on the same extremity or digit. And then if you go above and beyond those ischemia times, and again, for a digit, 12 hours warm and 24 hours cold ischemia times. So listen, it's not that these suck. There are still good outcomes here, but the point is, in the current healthcare landscape, patient selection, regional hand centers to give them the best care. Typically here, when we're making that call out from the trauma bay, we're either talking down to our colleagues at New York Med in Westchester or over at Syracuse at SUNY Upstate. Those are our two main ones, depending on the time of year or what their circumstances are. Certainly I left room for questions because I assume I'm going to get some, and I appreciate you guys listening to me.
So, sir, we've got a question from the field here. If at a hospital without hand coverage, will the implantation center expect us to transfer to you for hand eval, or will they talk to us?
I mean, it's a great question. I think, like all this stuff, it's going to be dependent on that accepting hand surgeon. But if you are at a outside facility and you have a hand injury and you think it meets these criteria and you don't have hand coverage, you're the one that's the eyes and ears for them, and you're the one that's making that call to the regional hand center. Again, unless there's an issue that they need to be resuscitated for some reason, and then you want to get them to us because we're closer. The knowledge that we are not one of those regional hand centers, and you think that you have something, hopefully not solely based on this talk, but also your experience, that is amenable potentially to replant, then you make that call because you're seeing that patient in front of you, would be my advice.
Dr. Mulligan, thanks so much on this. I already told your boss, who's also a hand surgeon, and hand surgeons seem to dominate the orthopedic because they're the smart guys. But I told Dr. Yule that it was a fantastic lecture because I think it really addressed, I learned a lot. I hope that everybody else out there learned a lot, but I think it addressed some really critical things that maybe I can capture and summarize, and then how we do things at AMC. Number one is that slide for our pre-hospital people out there about wrapping, salvaging, doing that. Don't make the call out there. And then, bring it in and try to reduce that warm ischemia time. Very instructive to me. Two is that I think Dr. Q wrote that lecture on the outside hospitals. We have emergency vet on there. I think some of the stuff that's presented in your slides, and Tom, the slides will be available on Sky, right? So I think for those people who got educated out there, absolutely, I think that trying to do a second transfer, because Dr. Mulligan, you probably don't know, that takes a lot of effort from these outside hospitals to get them here.
Right.
If they're an isolated hand, as you mentioned, and I think you emphasize this, without a resuscitative need, simply the hand, and there's not ongoing hemorrhage or a mechanism that has concerns for other one, I think that it's very important that you look at some of these two centers and be able to make that call using some of the information that you provided today to say, hey, this is a child, or this is a thumb, and the ischemia, the warm ischemia time is this, and we're currently, got the thing on ice and doing that. I think, and you can correct me if I'm wrong, that those are something when you were in hand fellowship, took those calls. Aren't those helpful information?
Listen, man, I got to tell you, you making me do this talk it gave me some fond memories of my fellowship, but it also gave me post-traumatic stress. I mean, when I was a fellow, I had the responsibility, because we covered Washington State, Alaska, Idaho, Wyoming. I had to, over the phone, because there was not a lot of technology even 15 years ago to do, pictures and videos. over the phone from a description from a local ED doc, I had to make a decision as the hand fellow. Do I put someone on a Lear jet and fly them to Seattle? And that was an awesome responsibility. When I was on call, that was actually what gave me the most angina is, am I going to get that call? Because I'm making an awesome, that awesome responsibility, and I don't have the ability to look at it and get an adequate idea. So you're exactly right. You have to, if it's an isolated hand and you're at a outside facility, there is a potential harm of, hey, just, the instinct of, oh, just transfer it to Albany Med because, then they'll be able to either A, take care of it, or B, do that like higher level. The problem is you have that limit on warm and cold ischemia time. So if everything else is stable and you are an isolated hand or digit injury, and you have a kid and it's a thumb and it's clean, you're like, hey, I need to call that regional hand center and I need to give them the most adequate explanation of what's going on with this patient that I can to make that decision to give them the best chance of survival.
I think Dr. Snyder has a question. Go ahead.
Yes, good morning. Good morning, everyone. I wanted to also thank Dr. Mulligan, who I consider a good friend. We talk frequently and work together frequently. Thank you for the wonderful talk. I did want to say to the EMS professionals regarding decisions in the field that certainly do not hesitate to call the attending in the emergency department at Albany Med. We field these calls all the time, specifically on burn patients. Do you go directly to the burn center or come to Albany Med where we are not a burn center? It's really analogous to the implant, reimplant, or replant situation. And so this is a tough call. It depends on your geography, depends on all the factors Dr. Mulligan talked about. And, given the cold ischemia time, certainly there is some time to make these decisions and have these conversations. Sometimes they are better done from the emergency department at Albany Med. We can certainly interface with the hand surgery attendings that are on call if we need to, and we can refer the call or have a three-way discussion or do whatever we need to do. But sometimes we do say, come to Albany Med where we can figure it out, especially if you're relatively close to us, then it's easier to get here. So thank you, Dr. Mulligan, and to the MS professionals. Never hesitate to call the attending in the ED and get some direction.
Yeah, that's a great point, Dr. Snyder. Thank you. And yes, I consider you a friend as well. But at the same time, what I was saying before was more on Kurt's question about if they're already at an outside hospital, but your points are very well taken when it's the EMS people, the pre-arrival people, don't hesitate to ask a question. Luckily, like Dr. Snyder said, if the ED is having trouble when you call them making that call, they know to get a hold of one of us, to make that decision. And I'm happy to, I field those calls frequently, whether I'm on call or not. That's part of my job, and I'm happy to do it.
So great question from the field here. Would you recommend extremely early photos and notification to Albany Med to decide transport destinations? And secondarily, do our photos and notifications get to the specialist quickly using something like Pulsera?
I can't really comment on the speed of technology, not my bag. But what I will say is, and it piggybacks off what Dr. Snyder said, we have more time if you're local, if you do these things and keep it on ice and all the parts, because the cold ischemia time is longer. So yes, do I want you to waste time trying to take like 5 pictures of this thing? Not necessarily, but if you see the part, clean it quickly, moist gauze on ice, and then give the information like you would do normally. Again, we live in this world of pictures. Pictures are great, but they're not the end all be all. We functioned pretty well in our world of healthcare before the advent of pictures, right? Didn't we? I think we did a pretty good job. It's just kind of like an added bonus that we have in some cases now. So I don't like relying on technology. I think that's dangerous. You want to use it to your advantage when you can, but it doesn't replace good care. That's just my opinion. So you want to, hopefully that one slide that I just kept going at, if you're in the field and you see the parts, take all the stuff, clean it gently, moist gauze, bag of ice, and then, in a bag of ice or on an ice pack, in a cooler, and then you've got your cold ischemia time started.
This is Carrie Snyder. So just so everybody is aware, and I talked to Dr. Mulligan about this before, this actually started today. One of our new requirements from the American College of Surgeons that we're going to have to meet for our next verification cycle is have a regional